Here we go, my diagnosis. All right. All right. Okay, Carl. Are we up? Are you ready? All right.
Look at your chat box just before we start.
Okay. Good afternoon, everyone. Thank you and welcome to MRF HIV STI Echo. It is a great privilege to have you join us today. So we have the distinct pleasure of having a guest speaker today, Dr. Arianne Brown Jordan. So Dr. Brown Jordan has a PhD in veterinary microbiology. She has extensive experience in molecular testing and research, and she was essentially responsible for a lot of what we do at MRF. So she set up the HIV molecular testing services. She was a key player behind starting the SARS-CoV-2 PCR testing laboratories in the various centers. And as a matter of fact, right now, it's one of the things that we are doing. We have a batch of the testing right now. So it is the fruits of her good work and her partnership with us. She has kindly agreed to have a conversation with us and to teach us about SARS-CoV-2 testing modalities, the difference between the antibody testing, the PCR testing, the antigen testing, and what the implications are both locally and internationally. So, Dr. Brown Jordan, thank you again for coming. Before we get started, just a quick housekeeping note. Just want to remind everyone, especially if you're new with us or if you're here with us for the first time, to indicate where you're joining us from, what is your field of work, and feel free to allow us to see you. We're quite happy so that we see everyone so we can help build community. So with that, Dr. Brown Jordan, over to you. And again, thanks again.
Yes, no problem. Thank you, everyone. So y'all can hear me just fine?
Yes, we can. Thank you.
Great. So thank you for having me. I'm really glad to be able to present to you guys today on the laboratory diagnostic side, for SARS-CoV-2. I will just jump straight into it, as you know, there's quite a bit to cover. So basically, there are two types of, the different test types, they fall into two groupings. Present infection, which detects the actual virus, the actual presence of the virus, and then there's fast infection, which of course detects the antibodies against the virus. So this is the main headings under which what will be presented today. So for the antibody testing, which I'll start with because it's shorter, the testing, it's to detect the presence of the antibodies in human serum. And so it's not widely available really and truly because the focus had always been on the molecular testing, that PCR testing. It's not widely available. It's not widely used, even though some companies have been developing it. Actually, in Trinidad, there's one of the RHA hospitals that is utilizing the antibody test, one of the antibody tests for their screening purposes. And as things have progressed with the pandemic, we've really realized that the antibody test just gives us a very limited results. In the earlies, when we thought, okay, there was coronavirus and that was it. And once you got infected, you got infected. There was no talk of reinfection at that time and all that. So now you can have IgG antibodies, yes, but you can be infected yet again with a different variant and so on. So, as time has gone along, we've seen the need for antibody testing decrease. There's some health workers who advocate for it. So for example, I was talking to one of my nursing colleagues and she said, the nurses in general have been, some of them have been apprehensive about taking the vaccine. And they really wanted to know, well, you know, why can't we have an antibody test then to tell us if we were previously infected? Because there are quite a few people who think, you know, maybe they came up into contact with the virus at some point, they weren't feeling ill, never got a test, but, you know, maybe they did have COVID. So in that instance, the antibody test will be able to tell us, you know, if we've had some sort of previous exposure. This is a, you know, we're very familiar with a lateral flow rapid testing device for the detection of the antibodies. This one is quite advanced, having a control line, an IgA, an IgM, and an IgG antibody line. And, you know, companies have been pushing it because it's very fast to use. You use the serum or the whole blood or plasma. It's easy to use, it's visual, it doesn't require any instrumentation. You can use it anywhere, anytime, no need for cold chain. Fairly reliable, flexible, and affordable. Fairly reliable because, you know, the sensitivities have usually been questionable at times with regards to some of the lateral flow rapid testing devices. Another main antibody test that we use, that can be used, are ELISA testing kits. So a traditional ELISA testing kit for the detection of either the IgG or the IgM antibodies. So very common as well for places that are using it, but again, it's not widely used. There are some countries that are able to use it, I guess, depending on finances, depending on the needs, etc., of the health authorities and so on. One of the main reasons, I mean, I just wanted to drop this in here, you know, why the antibody tests are not widely used as well now is because of, you know, the complexities of it. The viral load for SARS-CoV-2 is something that's quite variable for different for persons. So in this instance here, we're actually seeing the traditional, you know, waning after 3 weeks, but there are persons who have viral loads being present even longer than a 3-week period. And depending on the type of test or the testing system that's being used, sometimes the virus can be detected by that in that nasal swab for upward of 3 months even. So it sort of makes it quite complex when you decide to use an antibody test to determine whether the person is currently infected or if they are, if they've had a past infection. We also know that a past infection, we also know now that a past infection, so having IgG antibodies, doesn't necessarily mean that you are not, that you don't currently have the virus, because it could mean that you could have, you know, contracted a variant strain. You know, it's getting quite complex. And so the antibody tests are not widely used moving forward. So the antigen testing, it's basically divided into both molecular and non-molecular. So for the non-molecular antigen test, it's really designed as an immunoassay that detects the specific viral proteins that are present in this, you know, the specimen. It provides a rapid result within 15 to 30 minutes, depending on the type of test. And so it's a fairly good screening tool, and it's starting to be used a little more widely. This test sensitivity is it's poorer for weaker positives, because in this test there's no amplification. So we'll see when we go into molecular that there's an amplification where you sort of increase the target to see if it's present. In this case, these antigen tests, it's whatever is present in that small quantity of sample that you add to your cassette or your tube or whatever, that is what is going to be detected. So if it's in a very small quantity, then there might be some challenges for the test to detect it, you know, using this immunoassay. So that's why you end up having the weaker positives generally going undetected by this these methods, the non-molecular methods for antigen. So this is the one that we're very familiar with, the lateral flow or the chromatographic immunoassay for qualitative detection. So it tells you, yes, present, as in the virus is present. The specific antigens to the SARS-CoV-2 are present in the specimen or not present. So it's good to tell you if there's current infection. But again, you know, it has a limited use. It's a good screening tool, but it's not going to detect the weaker positives. So basically, a sample, you can kind of see the sample kit there, the actual collection kit. So the swab is taken, is added into that column that looks like a tube, and it's capped. And I think it's, you know, it's shaken a couple of times, and then that actually becomes a dropper. The cover here becomes a dropper. So it's shaken, and then you just put those drops onto the sample area of the device. So I know for sure we have some here in country. They're not yet being used. But we might see that coming on stream given the current situation. And it is something that countries have been using for screening purposes. We also have antigen fluorescent detection immunoassays, which will actually look for, again, the virus or the SARS-CoV-2 antigen in swab specimens. And this one, it is similar to the previous, but this one uses instrument. And given that we're detecting antigen, what it means is the antibody is labeled with some fluorescent probe. So the antibodies in the reagent that is applied to the cassette along with the sample. And so it anneals to the present antigen, which is in the sample, and then the instrument actually reads the result. The sensitivity is a lot better than the previous chromatographic test. And so these are being used quite, you know, worldwide, definitely. But the challenge is the numbers that it can run at one point in time, it's limited. So these in particular can do, the two smaller ones to the left of your screen actually can do one sample at a time, but you can actually apply the patient sample and the reagent outside of the machine. So you can line a few up, and then just slip them in the machine to get the result. But again, it's still limited in that it's one at a time for reading. Some of them, so the one in the middle, I think you actually have to apply it and stick it in the machine and then leave it for the specified time of 15 minutes or 30 minutes. And then the machine on the right, I think that's a larger volume of tests. But this is something that is going to be rolled out across some of the other hospitals. So we have our hospitals doing, our main hospitals doing the molecular tests, but some of the smaller hospitals will soon be able to do these more rapid antigen detection immunoassays. You know, so results can be more readily available for emergency cases and so on. So moving along onto the molecular side of it, this is really the gold standard, and it has been from day one. The real-time PCR molecular test detects the virus by identifying the presence of a specific target. And it actually goes on, it actually amplifies the target. So it makes copies of the target. So once the target is present in the patient sample, the test allows for copies to be generated, so an amplification. And then once that's amplified, it is, sorry, that's probably somebody jumping on. So once it's amplified, it is, it can be quantified, or it can be reported as, you know, present, not present, detected, not detected. The fully automated system, so there are quite a variety of ways that molecular tests can be done. Traditionally, it has been manually, especially in research labs, etc. Manual methods are more widely used. But then you have labs that use automated systems. So for example, the system at MRF, which is used for viral load testing, is also used for COVID. And that is a fully automated system, or considered to be a fully automated system. Of course, the technicians have some work to do at the beginning with loading all the reagents into the instruments, and then individually pipetting samples into tubes, adding any buffers and so on to those samples before they're loaded into the instrument. So that initial sample handling process does take quite a bit of time, but thereafter, you know, it is fully automated. And the time really can vary depending on the type of the system. And then manual methods as well. So that extraction process that's done before it goes on to PCR, that extraction process where all impurities are removed sort of from the sample, and you get a pure RNA or pure DNA specimen. That extraction process, if done manually, takes a very long time and it's very labor intensive. So CARFA as well as TPHL uses manual extraction methods for that process. It is, even though it's labor intensive, you know, it's quite efficient once you have a good workflow. It allows you to do smaller volumes sometimes, so it's scalable. It's a lot more scalable than an automated system. And then, of course, molecular methods, they have the best limits of detection, which is why they are considered to be the gold standard compared to other types of tests. They are said to be more sensitive, but limits of detection also would vary from kit to kit, system to system, and so on. So this is actually the gene expert, which, you know, it's a hot number. Labs all over the world, private labs, government labs, everywhere. Everyone is trying to get their hands on a gene expert. It comes out of the US, and so it's challenging to get out and to get a hold of. It is a molecular test that is done very quickly. Gene experts have been around for a very long time. I think it's upward of 12 or 15 years now. And they were primarily rolled out they have a very wide panel of tests you can use them for, but they were primarily ruled out for and used for TB testing. So they're very popular for country programs and so on for TB. So TPHL had initially had their gene expert for the TB tests. So SARS-CoV-2 tests have been created for them. Cartridges have been created to use in them. And this test is ready in 50 minutes. And so they're different sizes. This one we're looking at is a 4-module system, but there are also 2-module systems. You have 16, and I think they have a really large number as well, up to 90 something. But it allows for some very easy and straightforward molecular testing. The technician literally adds the swab, the viral transport media from that swab specimen, a couple drops into the cartridge in one of the sections to the top. It's popped in the machine, and it starts, and then you get your results in about 45 to 50 minutes. So it's a hot number, but it's really difficult to get a hold of. So even countries are struggling to procure them. They tend to come through donations more than anything else. So UNDP, maybe CDC, WHO, those are the routes through which gene expert cartridges are accessible. And when you do get them, you get them in very small quantities. You get a batch of 5,000, you get a batch of 2,000. It's really difficult to get a hold of. And in the earlies, of course, maybe about 8 months back, it was just impossible to get the instruments as well. I know the country recently got a couple new instruments, maybe 2, to sort of help with the current situation. There are also a slew of other Johnny-come-latelys with this type of system coming out of China as well. So there are other brands, but this is, a very known and popular brand. So, it's very sought after. A fully automated system for the testing looks something like this. So there we have our lab staff. As I mentioned, the work really is at the beginning, where they actually have to prepare the sample before it's loaded into the instruments. And then to the right of the screen, the technician is actually loading some of the other reagents that need to go in, and the tips, all the consumables, all the waste items that are going to be used, changing waste containers and so on. That's being done. It's loaded. The instrument puts everything on a plate. You pop the plate into the PCR machine, which is in the center there, and you get your results. So this is able to do 92 samples, about 92 samples at a time, just as it does for viral load. Depending on the virus that's being detected, you'd have variations within a time frame for this system to work. So the M2000 system actually runs for about 8 hours, I think, plus 8+ hours when it's doing COVID testing. Now that's because we starting off with an RNA virus. So, we have to go to a copy DNA before it goes on to do the PCR portion as well. So it can be quite lengthy. And of course, when you have samples coming in by 300-400 a day, and then you have this running 90, 92, 94 at a time, it's quite challenging to keep on top of. You really have to have a excellent workflow going to make sure you can keep on top of your numbers that's coming in. And so this is just a snapshot of a manual sort of setup for a PCR testing lab. So on the workbenches there, we actually have persons doing the extraction process, which the instrument in this previous picture would actually do. And so one technician can do about 10 samples at a time, and it can take that technician about 1 hour to get the entire process done. So it is quite labor intensive, especially when there are loads of samples. So, you know, it's important to have a good workflow even in the manual setting. Even setting up the PCR plates with 90 something, you know, requires a technician to go into each one of those wells with reagent, with sample. And so it takes quite a bit of time to set up and do. Regarding the interpretation, I just will touch a little bit on this. The molecular tests really, it really is to tell you if the virus is present or not, so detected or not detected. It's sometimes, you know, you might see positive, negative, but not detected doesn't necessarily mean that the person was not positive. Of course, there are reasons why that might be so. You know, molecular tests are very sensitive. Their errors can be made along during the process. The sample quality, that the sample that you actually get, if it's, you know, if the viral transport media was inappropriate, if the sample was poorly handled, you know, all these are factors that can cause a, you know, a sample that's supposed to be positive to not be. So it's really better to see detected, not detected. In terms of the quantitative results, CT value normally comes with the results, which is actually the copy number determined by the testing procedure and the cycle number. And this is one thing that you know, we sometimes hear people, you know, fussing over, you know, what is the cutoff for the test. If the value is 32, you know, should we consider it as detected? Should we not consider it, and so on? So it's usually an area of contention. But generally, higher CT values, as in the CT value number is higher, those samples are considered to be weaker positives. And then lower CT values in the teens, so 16, 15, those are really strong positives. But then there are testing systems. So we have this issue in Trinidad as well. There are testing systems that report a CT value or CN value. But the way the test itself was designed, so how the manufacturing company designed the test, they have dual targets. So we spoke about the target being detected. Usually in a traditional setup of a real-time PCR, you have one target. So we have companies that have produced tests with a double target. And so it creates it gives a false value sort of for when you get the CT value. It's not correct because you're actually checking a target. You're checking two targets when you really should be checking for one. So there are issues sometimes with interpretation, and which is why, you know, some persons have to have quite a bit of understanding when they are looking at the results and deciding whether to report them as detected, not detected, or positive, negative. But usually these systems give you the results. So those automated systems that we looked at, so the Abbott as well as the Gene Expert, they actually work everything out nicely for you, and they tell you, okay, this is the CT value, the result is detected or positive, and it's not, and so on. The manual system, sometimes there's room for interpretation. And then of course there's the internal control present as well, which is detected as a target. In most of these systems that we have going, there's an internal control really to tell you if the sample was, it went through the entire process, if it went through the entire process correctly, to give results at the end. So a couple of challenges with the molecular detection system. So even though it is the gold standard, that whole limit of detection, even though it has the best or the better limits of detection compared to other types of tests, it's still a challenge, because what we have is different systems. So we have the gene expert. So the gene expert can detect upward of 250 copies of the virus. So those are viral copies per milliliter of sample, or of your extracted RNA. And then you have systems that can detect closer to 100 copies per mil. And then there's one here, TACPath, and they self-reported as saying they can detect 660 copies per mil. So that kind of variability is a challenge, because what happens, I might get something positive on the Abbott system, which has a really good limit of detection. But when I run it on another system, or it's run at a regional reference laboratory or an international laboratory, they may not get it as positive because the system they may be using doesn't allow for, it doesn't have the same limit of detection as the gene expert. So there's some challenges there when you try to test across different systems. The sample handling, of course, as I mentioned earlier, the whole testing process, environmental conditions as well, those can certainly affect the detection of the sample, of the target, sorry. And of course, that could lead to either false positives if they're contamination, or false negatives if there is degradation of the sample, if something has destroyed the RNA. RNA is very fragile. So, this whole process can be tricky sometimes if not done properly, right? So there's also the concern with molecular detection, the residual detection of virus, which occurs in some assays. So a person can be detected as positive for upward and over 3 months, and so on. So we see that a lot, actually. Here, because of the testing systems we have. So samples that are really weak or weakly positive, they can be detected, as mentioned before, they can be detected on some systems, but when you test it on another, it comes up as negative. But you can have residues, so the virus is no longer whole and intact and replicating and creating new copies of itself. So there are leftover bits in the passages, and when that swab is taken and the sample is tested, it comes up as positive. So that happens. Of course, that's a challenge, again, as mentioned before, especially when you try to test and compare across different systems. Now, the challenge with the molecular testing is mutations. Because we have mutations occurring and variants coming up and so on, and new strains and so on, what's going to happen is that your testing kits, you probably need to continually have a look to see if they're still effective at detecting different variants. So manufacturing companies have that, they have to very regularly use their kits and check them against variants and other strains to make sure that they are always detecting the target, right? And in an event when they're unable to detect the target, then they need to do some modification on their end to make sure that it's covered. So it's always good also for testing labs to have other brands of tests and alternative tests just to make sure that it's being covered. So as a quality check. Let me go on. And I just wanted to touch also on the sequencing aspect of it, because I know it's something that we're doing now. So the sequencing really is intended to allow the analyst to have a look at the entire genome or a part of the genome it's interested in to determine if it's different from the wild type or other circulating strains of the virus, right? So it is conducted after the sample has been confirmed as positive by PCR testing. So the sample must be first confirmed as positive, and you must have a favorably high viral load, so a lower CT value within the teens or early 20s to go on for sequencing. So in other words, all samples cannot be sequenced. So next-gen sequencing, this is just a quick snapshot of the next generation sequencing that's done. I wouldn't go too much into it, but it just is that the system produces lots of copies of the genome, and it sort of puts it together into a cluster. Sorry about that. Puts it together into a cluster, and then as it builds, so it amplifies and amplifies and makes lots of copies of itself. And then when it goes through the sequencing process, you know, the different reads are aligned, and it's able to generate one long read of the viral genome. So the aim really, it would actually lead to you getting a nice sequence of your nucleic acids, which is the entire code for the virus, basically. And then they are able to analyze the code that they get and compare it against the wild type codes and any other genomic codes that they have saved. So that's the whole analysis process. But what it's saying to us, though, we just try to have a look at this. We have our original DNA code or RNA code on top, and it codes for an amino acid sequence. So we have the amino acids below. And so anytime there's a mutation, which happens very regularly with coronaviruses, you can have a replacement of a single nucleotide, a deletion, so on. And those can lead to changes in the amino acid reads. And if a change occurs in the amino acid reads, it means that you can have a change in the protein that it codes for. So, which is what we're seeing happening now. So our spike protein, which is very popular, everybody's talking about the spike protein because that is the antigenic portion of the virus that's responsible for attaching to the receptor. So when there is a change, or let's say there's a single nucleotide amino acid change, it can affect the folding or the conformation of the spike protein. And then what that means is that perhaps the antibodies that we already have through natural infection, or the antibodies that we have because of the vaccine that we took, what it means is maybe those antibodies may not be able to detect this mutant or this variant this variation in the spike protein. Right, so that's what happens when we talk about vaccine evasion. So there's quite a lot of interest in sequencing, and much needed, because it really will provide information, you know, for what should we do next, you know. And so the challenges with sequencing really are that there's a strict criteria regarding eligibility. So for one, your sample has to be a fairly strongly positive sample. So not all positives will be sequenced. It's so expensive, it's very expensive. Also, of the, of the 399 positives that were detected yesterday in Trinidad and Tobago, all those samples cannot be sequenced. And so we will not actually have a fair understanding of what, what the presence of the variants are like for Trinidad and Tobago. We can only sample strong positives. Of course, the sample has to be of a certain integrity, so it must be maintained at a certain environment to be valid to go on to the next, go on for sequencing. So what we're currently seeing really is some community circulation of the variant, of the P1 variant here. We're not ever going to be able to get a full picture of the actual number of variant cases. But importantly, I know WHO has been working to, PAHO as well has been working to try to get countries test kits, so real-time PCR test kits that allow them to identify the variants, which would be excellent. So you just do that same process for detection of SARS-CoV-2. That same process is done for identification of variant strains. Of course, it means, a lot more resources as well, because it's quite labor intensive. So I just wanted to touch on PLHIV, since this is, being done out of MRF, I really want to encourage the advocacy for partnership and blended services for persons requiring a test. It's best for some kind of arrangement to be made. I think it would provide quite a bit of ease to persons wanting to get a test, because, going through the usual system can be quite challenging. It is a good idea to try to seek to obtain a rapid antigen testing system for point of care. So the ones that we looked at, where the test can be done in 15 to 30 minutes. It might be one or a few at a time, but it's a good, it provides a very good screening tool for use at clinics. And so that's something I would probably encourage you guys to seek out. And of course, it would be nice to try to establish policies and procedures if you all have not already done so, of course, for care for persons who are infected with SARS-CoV-2, right? To try to remove as much as possible any barriers for hospital care, when they go to other facilities and so on. So I think that is the end. Thank you very much for listening. Of course, I am open to take questions because, of course, I may not have covered everything, or you may have a burning question about some aspect of the laboratory diagnosis or testing. Thank you.
Thank you, Dr. Brown-Jordan. That was very comprehensive and very informative as well. I learned a lot from that conversation. So I'm brimming with questions, but I'm not going to hog the mic. So I'll open it up to anybody if they had any questions you want to put to Dr. Brown-Jordan. Feel free to unmute yourself and ask your question. If you can't talk where you are, you can always type in the chat box as well.
Arianne, this is Jeffrey Edwards. In terms of testing for COVID-19, I mean, when is the best time to test? I mean, some people are asymptomatic. Is the viral load higher when they're symptomatic? I mean, sometimes people do a test and come back negative, and then they may actually have the virus, so it might be a false negative. So when is the best time to do the testing? You know, that's what I'm asking.
So the test, so it's it's challenging, especially when you have asymptomatic and symptomatic. But if we're looking at symptomatic cases, persons who have symptoms upward of 3 days, they've had, they've been having symptoms for the past 3 days, those are ideal and prime times to get a swab taken for testing. But what we do know is SARS-CoV-2 can live on for quite some time. So even if a person gets tested later on, maybe after a week and a half of having symptoms, it's highly likely that that person will actually still be positive. Asymptomatic cases, so we've seen quite a lot of that, persons who've said they don't have any symptoms at all, no fevers, no headaches, they might have a slight sore throat. And even those persons, when you test them, you can actually get a very high viral load in the teens. So they have the virus just like, somebody who is very symptomatic and hospitalized. They have that, very high viral load. It's very present, but they have no symptoms. So we actually don't, it's very difficult to, I have someone come in here. 1 minute, please.
That's fine. You can always say hi. Right, good kid, sure. So while Dr. Brown-Jordan is away briefly, just want to, again, quick housekeeping note. For those of us who are new, again, welcome. We're very happy to have you. Don't forget to indicate what your name is and where what your job title is and where you work for records keeping purposes as well. Thanks so much.
Okay, so I am back. Yes, so I did mention before that I had a smallie with me and he might barge in here. So the TV stopped, so I had to go and put it back on. Yeah, so Dr. Edwards, I hope I answered your questions.
Yeah, yes, you did. And one more, in terms of the antigen testing, because apparently, I mean, the US is accepting, instead of taking they're accepting both. They're accepting the PCR and the antigen tests. And I know of a couple of companies that are actually doing antigen tests in Trinidad where they get a result in say 15 minutes. So once the antigen is present, you can say that the person has COVID-19. I mean, how long does the antigen last? I mean, like I know for the HIV, the P20 for antigen lasts a very short space of time. How long does the antigen last? I mean, if you're doing the antigen testing.
So the antigen test they are quite good. So those are the ones that I mentioned that y'all could probably try to advocate for, which does the test quite quickly, 15 to 30 minutes. Yes. The challenge with the antigen test is that the weaker positive. So persons who are maybe 2 to 3 weeks into infection, they've already started clearing the virus. Those can likely come up as negative. So it's a good screening tool, but it's not the best. It's only slightly poorer than the molecular based test. What I do know is that Caribbean Medical Labs Foundation, so CMLF, had been working on rolling out antigen tests for Trinidad and Tobago through PAHO. And they have done a study, before the rollout. So they have data to support the performance, but the sensitivity is not bad. As I mentioned, it really is just the weaker samples that come out as neg. And yes, in terms of the reporting, antigen, so one of those rapid non-molecular antigen based tests, those are being reported as, in some countries, yes, are confirmed. Those are being reported as PCR, as positive, sorry, not as PCR, as positives. Those are being reported as positive SARS cases. And so persons are being, put through whichever systems, if they need to be hospitalized, whatever, based on those tests. They're not actually sending it along necessarily for confirmation by a molecular method, because the antigen detects the actual presence of the virus. It's just only slightly poorer than molecular-based tests.
Dr. Brown Jordan, I'm seeing a question in the chat box. This is, my eyes are good enough. The COVID testing relies mainly on the symptomatic people or those deemed to have been in contact with infected individuals. It is clear that there are many asymptomatic people too. Are we missing the spreaders by concentrating on testing suspicious individuals only? And if so, how can this be changed in the public sector, given the cost involved, if there was to be more testing, especially healthcare workers, for example?
We are definitely missing spreaders. Asymptomatic cases are of major concern, because asymptomatic persons will go along with their lives, continue on go to their supermarket if they're going to have a line when it was allowable, so it is leading to spreading events, which is why, measures were taken to limit significantly the movement of people. We are missing quite a few people, and testing suspicious individuals only. Yeah, that's happening too. But what the problem is also is that a lot of people who may have symptoms might feel stigmatized, so they're not going out there to get any tests. They are fearful. They're afraid of what the results might be, what it might mean for them, where will I quarantine? People have quite a few concerns and questions. So we have quite a few people as well who have symptoms and are not seeking to get a result and to get into the care that's available. The public sector, I would advise, there are quite a few things that are being done in other countries where they're allowing self-testing, or at least self-collection. That is something that's being done as well. So the actual collection device or the swab is being sent to the person upon request, or they can collect it at a certain location. They can go home, they can do their own swab and have it sent or picked up and so on for testing. So, there's some countries that are taking extra steps to make sure they capture as many people as possible. And so, yes, we probably need to start looking into doing that. But there would be, quite a significant level of cost added to it, because laboratory is one of the most expensive areas in healthcare, and it is also grossly under funded. So it would mean quite a lot. But yeah, we probably do need to step up some of our measures to try to make sure we capture as much persons as we can and make sure we keep the virus from circulating.
I was wondering, with respect to the detection of new variants, so once there is a lot of background replication, a large outbreak, you'll get these variants appearing randomly, and some of them may be of concern or be of interest. How would we detect if, let's say, a Trinidad strain
Yes.
right? Because everybody has their own strain now, apparently.
Yes.
How would we?
So it's actually very. It's actually the sequencing, the whole sequencing. Doing the sequencing, the wild type virus strain, you know, is the main one which everything else is compared against. And, you know, this is a question actually that I did ask Professor Carrington at one time, you know, what are the chances of us having a strain, you know, coming up about in Trinidad, that's specific to Trinidad. And at the time when I asked her that question, you know, she said, you know, the circulation, the amount of spread that we have going on, it was limited. So the chance of that happening was fairly low compared to what had been happening in Brazil, of course, and in the UK, you know, where they had been having, you know, very large numbers of cases. So of course, the greater the number of cases that's happening in a country is the greater the chance of effective mutations coming about and variants arising. So the sequencing team out of the University of the West Indies, Prof. Carrington's lab, and I know CARFA has also, or is trying to start up sequencing as well. They actually have a look at, you know, where the mutations occur along the genome, and if it is that it looks like something that has already existing. So if a mutation, if there's a you know, a couple mutations along a certain area, and it looks like, okay, these mutations are also similar to what's in the P1 variant, then it will be classified as P1. But it's not to say that those mutations cannot occur separately. So it can happen, you know, and variations, even mutations, sorry, in other portions. So they will be able to see if there are variations in other portions of the genome. You know, the whole analysis process is sometimes quite tedious. And then they also submit you know, these analyses to you know, larger bodies or groups that have a look to confirm whether the mutation that's being seen is going to lead to designation of a new variant, if it's effective, like if it's going to actually lead to some sort of notable change for the virus and so on. So it's quite complex, but there is the potential for a variant to arise, yes, in any country where there is you know, a large number of cases and a lot of spread happening.
All right, thank you very much for that. So I will copyright it to the Trinidad variant in the next few days, just in case. So we're edging close to the 3 o'clock time. I'll just invite anybody, if you have any remaining questions, again, feel free to submit them to Dr. Brown Jordan, who again, we want to thank you for your time and for your expertise, and again, for your service, because, you know, we are in a point in time where, you know, we need all the help we can get to get us through this outbreak and this pandemic. So
Yeah.
so Dr. Edwards, sorry?
Yeah, Arianne, so a prominent person in Trinidad was tested positive a couple of weeks with the virus. When do they consider, I mean, you can come out of quarantine. Are you any negative for the virus? When do they decide, you know, or is it a certain time pass? How do they decide you're no longer infectious?
So the policy of the ministry had been to initially I'm not too sure what it is now, but it had been that you need to have 2 consecutive negative PCR tests to be released from quarantine. What they have been advising persons now, though, because of, because everybody who's infected with the virus, it can, it can be different for you. Your virus, your viral loads may last for a longer time. It might take a longer time. The virus may take a longer time to wane, development of antibodies and all that. It's variable. So even after you've received your 2 negative PCR tests, usually it's a good idea to still be very cautious, to always wear your PPE still, especially when going out into public spaces. But I know the advice has been to 2 negative PCR tests. I know they don't do that anymore. So even when they get a negative, sometimes they tell persons to still quarantine for another 2 weeks at home. It has been changing. It has changed over time, especially with the surge in cases. But the aim is to ensure the virus does not circulate. So even if you have left quarantine, you still have a responsibility to your family members, your friends, your colleagues, and to the general public to keep them safe. So the best advice is always to make sure you always wear your PPE still, your mask, wash your hands, and as much as possible, try to distance. It's very variable. It's difficult sometimes to give a general statement of what we should do across the board. It's too variable.
Okay. All right. Thank you again for that. And we are at the end of another MRF HIV STI Echo. Thank you everyone for coming and for participating. I think we've all learned a lot. We shall be back in 2 weeks' time. Remember, next week is a holiday. So we shall see you again the week after Eid. And happy Eid to anyone who may be of the Muslim community with us today. Be safe, be well, sanitize everything, and we shall see you in a fortnight. Take care, everybody. Bye-bye.
All right. Take care. Thank you.